Good afternoon, everyone. My name's Diane Faison-Rowe, and I am a member of the outreach team here at SunCloud Health. Thank you for joining us today for our National Collaborative Learning Series and today's presentation on the intersection of PTSD with eating disorders and addiction. At SunCloud Health, we provide a full continuum of care, behavioral health care services for both adults and adolescents, including residential, PHP, and IOP. Our approach is highly individualized, combining evidence-based treatment with integrative care to meet each patient's unique needs. We specialize in the treatment of complex co-occurring conditions, including substance use disorders, eating disorders, mood disorders, trauma, and other mental health challenges. Our multidisciplinary team is dedicated to helping individuals achieving lasting recovery and improved well-being. SunCloud Health proudly serves patients throughout Chicago with locations in Northbrook, Lincoln Park, Naperville, and Madison, Illinois. Currently, I'd like to note we have immediate availability for adolescents in our PHP and IOP at our Chicago Lincoln Park location. So you can reach out to one of our outreach team members to immediately schedule an assessment, and those that are joining us today will go ahead and put their info in the chat. And then their information will also be at the end of the presentation. So just a few housekeeping items before we begin. This session is being recorded for educational purposes and will be available on our website for later viewing and sharing with others that maybe couldn't attend today. And they can still receive a CE credit for watching the recording. We encourage your participation and welcome your questions throughout the presentation using the chat feature. To ensure we have adequate time for discussion, we will reserve dedicated Q&A at the end of the presentation. So please feel free to submit your questions as they arise, and we will address them as many as possible during the Q&A. For those attending for continuing education credit, you'll receive an email following today's presentation that includes both a quiz and a survey. Please complete these requirements to receive your CE certificate. Your CE certificate will be emailed to you, and you should expect to receive it within about 7 days of submitting the required materials. The follow-up email will also include a link to leave a Google review if you have had a positive experience with SunCloud Health's continuing education programs. And then at the conclusion of today's presentation, we will share links to register for our upcoming C events. We have another one scheduled for next month, and then we have our new fall series that's going to be coming out soon. And I do want to say, if we're unable to address all your questions during today's session, please go ahead and email one of us, and a member of our team will be happy to follow up afterward. But now it is my pleasure to introduce today's presenters. Michelle Duda holds an MS in clinical counseling psychology from Illinois State University. She is a licensed clinical professional counselor, LCPC, and certified alcohol and other drug counselor in the state of Illinois. Prior to joining SunCloud, Michelle worked in various roles, including overseeing residential, outpatient, interim housing, harm reduction, veterans, recovery homes, and methadone treatment programs. Michelle believes strongly in the use of individualized, evidence-based, and holistic approaches to treating both substance use and mental health conditions to address the many components of wellness and recovery. She strives to create a safe, non-judgmental, genuine, and collaborative relationship with every client she works with. In her free time, Michelle enjoys traveling internationally, spending time with friends and family, and going on adventures with her dog. Kelsey Fontano is a licensed professional counselor specializing in child and adolescents with anxiety, depression, co-occurring mood disorders, and PTSD. Kelsey brings experience working in PHP, IOP, therapeutic day schools, and private practice settings. Her background includes a Bachelor in Arts from Coe College, and Master of Arts from Roosevelt University. Kelsey believes that each person has their own story that has shaped who they are and their current experiences. Through her work, she strives to foster a safe space where clients feel comfortable telling their story, gaining insight into how has impacted them and create a new reality that is more fulfilling. Kelsey utilizes a variety of therapeutic approaches, including cognitive behavioral therapy, narrative therapy, family systems therapy, and humanistic therapy. So those are our presenters today. You're in for a real treat. This topic is really near and dear to SunCloud's heart, being that this is something that we definitely specialize in, having our Institute for Eating Disorders and Addiction, specifically treating these two. So you're in for a treat today. So without further ado, I'll turn it over to Michelle and Kelsey.
Thanks, Diane.
Thanks, Diane. So today we're going to be talking about the intersection of trauma, eating disorders, and addiction. Some of the things that we'll be going over today include understanding some of the rates of PTSD, eating disorders, and substance use, as well as understanding the overlap between these disorders as well as other psychiatric conditions. We're going to talk about implementing screening tools for all of these diagnoses and become familiarized with different empirical supported treatment modalities so we can incorporate well-rounded integrated treatment. And lastly, we're going to talk about some different multidimensional aspects of recovery.
All right. Sorry, I think there's a little bit of a lag as I transition these slides here. Okay, so first we are going to go over some background information, just a little bit about rates of PTSD or post-traumatic stress disorder, eating disorders, and substance use disorders, and then also review a little bit about the overlap that exists between these different conditions. So to start off with PTSD or post-traumatic stress disorder, so based on the highest quality estimates identified, we know that the 1-year prevalence of PTSD in the United States ranges from about 2.6% to 6% among civilians and 6.7% to 11.7% among veterans. And the lifetime prevalence ranging from 3.4 to 8% among civilians and then 7.7% to 13.4% among veterans. So kind of looking at these statistics, we know that this is a very common and prevalent condition that many folks will experience at some point in their life. And then a little bit about what can happen with untreated PTSD or trauma. It can kind of overlap into the development of a lot of other mental health conditions, which we'll talk a lot more about today, including eating disorders, substance use disorders, and then mood disorders such as depression and anxiety. And then untreated PTSD has also been found to be linked with other physical health problems, such as increased inflammation in the body, cardiovascular disease, chronic pain, sleep disturbances, weakened immune system, digestive issues, and other, physical complications as well. And then something else to note too with PTSD that is important is that not everyone who experiences traumatic events ends up developing PTSD. And it suggests that multiple factors, including biological, social, and other psychological elements, influences how an individual experiences a traumatic event and is able to respond to it. So the development of PTSD or the ability to recover is complex and usually involves a variety of factors.
When it comes to eating disorders, an estimated 9% of the US population has an eating disorder within their lifetime. 15% of women will struggle with an eating disorder by the time that they're in their 40s or 50s, but only 27% of them end up receiving treatment for these. The other piece that's really important to note is that anorexia has one of the highest mortality rates and second highest crude mortality rate of any mental illness. So not only are these so prevalent in our populations, but they're not being treated and have a really high mortality rate. Over 70% of people with eating disorders also have other mental health conditions, and typically they have between 1 and 4 other psychiatric disorders when they're struggling with an eating disorder.
Okay, and then moving on to substance use disorders, a little bit of statistics and background here is that in 2024, 48.4 million people in the United States, or about 1 in 6, met the criteria for a substance use disorder. And in 2024, 52.6 million people were in need of substance use treatment, but only 1 in 5, or about 10 million people, received any treatment for their substance use disorder. And in 2022, about 110,000 people died of drug overdoses, and Black and American Indian and Alaska Native people are estimated to have the highest rates of fatal overdose. Another thing I want to note here when we think about conceptualizing substance use disorders and addiction in this presentation is that our modern day society, we live in a very pleasure saturated environment that makes like highly rewarding substances and behaviors very easily accessible and normal and hard to escape. So when we conceptualize and think about addiction, although many addictive behaviors or other addictions aren't notated in the DSM, we realize that a lot of behaviors that we engage in, such as like social media or like online gambling or different behaviors that we have such easy access to today, can also be conceptualized and viewed as addictive and also conceptualized as addiction. And so we want to kind of in this presentation, like think about those other behaviors as well.
Yeah, I think a lot of that can also come into kind of the eating disorder PTSD world. And we'll get into that too with some of our assessments because we want to screen for those as well. Some of the other things to consider when we're talking about some of the intersection between different diagnoses. So, for example, PTSD and eating disorders is that traumatic events can be found as a significant risk factor for developing other psychiatric disorders, including eating disorders, particularly those involving some sort of symptoms of binging and purging, such as binge eating disorder, bulimia nervosa, and anorexia nervosa binge purge type. The highest rates of lifetime trauma among those with eating disorders were found to be 54%, 100%, and 74% respectively for those diagnoses. When we think about that as well, some of the other studies that we've looked at, swap slides, look at young adults in the United States that found that those who experienced multiple forms of childhood trauma were almost twice as likely to report eating disorder behaviors compared to those without a history of childhood trauma. So we're really looking at not only are these two pieces independent, but when they come together, the rates increase. And that's why it's so important. We're going to touch on this further to make sure that we're treating the whole person with all of these different puzzle pieces put together rather than a solo diagnosis. So another research on active duty military and veteran populations have consistently found that those who are exposed to military-related trauma are more likely to develop an eating disorder, to experience more severe eating disorder symptomology, and to have co-occurring mental illness like PTSD, substance use disorder, depression, and sleep disorder. So this prevalence increases based off of all these factors.
And now to explore a little bit about the connection with PTSD or trauma and substance use disorders. So among people treated for any substance addiction, about 1/3 of them have active PTSD. And among those with PTSD, about 58% have had problems with substance use. A 2021 review found that more than 40% of people with an opiate addiction reported some type of childhood abuse or neglect, and 41% of women had been subjected to childhood sexual abuse at rates much higher than those of the general population. And a different study showed that among those with any type of addiction, at least 85% have had at least one adverse childhood experience, with each additional experience raising that risk of developing a substance use disorder. I feel like this is something that's been deeply explored over the past several years and really kind of establishing further the link between trauma and the development of a substance use disorder or addiction. And I think a lot about Dr. Gabor Mate's not why the addiction, but why the pain. And so kind of conceptualizing addiction or having a substance use disorder not as a primary disease, but as something that develops from a desperate attempt usually to soothe deep emotional suffering. So we usually rarely find folks with an active substance use disorder or addiction that don't have a history of trauma or PTSD. And then with substance use disorders and eating disorders, the rate of substance use disorders among those with eating disorders is high. Approximately half of all women with eating disorders also struggle with addiction. Up to 35% of individuals dependent on alcohol or other drugs have also had eating disorders, which is a rate 11 times greater than the general population. Up to 50% of individuals with eating disorders use alcohol or illicit drugs, a rate that's 5 times higher than the general population. And roughly 1 in 5 individuals with an eating disorder will develop a substance use disorder at some point in their lifetime. I find these statistics very important, and also I feel like they are not talked about enough. And it's also also very interesting and important to note that there are very few primary eating disorder and substance use treatment centers that treat and are qualified to treat both of those conditions simultaneously. And so we find that folks who are struggling with both of these things frequently will be getting one of those addressed, but really not able to address the other things that they might be struggling with. And given the co-occurrence of these things, it's really less likely that someone will be able to recover without more integrated treatment to address all of the different things that they might be experiencing.
And I think that directly goes into the gaps in treatment that we're seeing, right? So despite all of the research showing that integrated care is necessary to treat all of these diagnoses and to treat a whole human, we're still seeing that a majority of individuals that are experiencing multiple psychiatric conditions at once are still seeking and still experiencing treatment that is frequently siloed. So some of these, what it looks like is partially due to some billing structures. Typically, insurance is billed based off of a primary diagnosis. A primary diagnosis indicates that that is the main thing that they're being treated for, even though there may be several other diagnoses that are not being treated as such. We're also looking at siloed healthcare systems. Mental health and substance use operated completely separately. So we need to do sequential treatment. I can't tell you the number of patients that we see that come with a that or have been in treatment for a primary eating disorder. Once that is more at a functional level, then they have to go and treat their substance use disorder. Then they have to go treat their self-harm. So they're having to go back and forth instead of being able to treat everything all together. Some of the other gaps and barriers in treatment include the time and logistical constraints. If you are focusing on one symptom, that might be a quicker course of treatment. When you're needing to focus on all of these different diagnoses, typically it's a lot more integrated, it's a lot more complex, and that means this treatment is going to be longer and more complex to really get back to a more functional level. Diagnostic overshadowing is really difficult for these comorbid cases because it's difficult to see what's the stem of this. Where is this coming from? How are the other symptoms and factors interplaying with each other? And the other piece that Michelle touched on is a lack of specialized training. Most people, if they have a specialty, it's in one field. Very few practitioners are specialized in eating disorder, substance use, and trauma. So when we're dealing with people who have multiple diagnoses, they might not have the experience in handling the complexities that this is with.
Oh, sorry, I'm having trouble with the slides. Okay. So now to shift a little bit, we are going to review different empirically supported assessment tools to assess and kind of monitor symptoms for folks with trauma symptoms, eating disorder symptoms, substance use disorder symptoms, and then also some mood questionnaires as well. And so it's helpful to use these sometimes in the beginning as part of an assessment to kind of gauge where someone is at when they're entering treatment. And it's also helpful to use these in treatment planning to kind of see like what symptoms someone might be experiencing, make sure that we have a really full, complete picture of what someone is experiencing when they're entering treatment. And then it's also helpful to do these periodically while someone is in treatment to track their response, their progress, their improvement in symptoms. It's also really good to do a variety of these to help possibly catch missed or overlooked things that we might have missed during an assessment or just not have asked about. So we just wanted to review these and go into detail a little bit about which ones that would be helpful for assessing for these things. So a couple other things to note, it will mention sensitivity and specificity for many of these. And so sensitivity meaning how good the test is at finding people who have the condition, and then specificity meaning how good the test is at correctly identifying people who do not have the condition. So starting off with the PHQ-9, which is a pretty common self-administered depression screening, which asks patients to rate their symptoms over the past 2 weeks using a 4-point scale. And then depending on adding those numbers up, will give us a number to kind of gauge how severe their depression might be.
And then we'll go into the MyFAST. So this is the modified Yale Food Addiction Scale. And this is a 13-item self-report questionnaire that looks at symptoms of food addiction. So it's a 7-point scale, and it also scores between like 1 and 6 plus, and that goes into the level of food addiction. A couple things to keep in mind for this one is that the 13 items, 11 of them look at symptoms, while two look at impairment and distress questions. So it's not fully based on symptoms. Some of the limitations for this as well is that this is based off of diagnostic criteria for substance dependence in the DSM-5, since food addiction is not officially recognized in the DSM-5. So there may be a little bit of overlap as well with some other eating disorder conditions with this one. So this one needs to be taken with a little bit of modification due to the limitations in the DSM.
Okay, and then next, another eating disorder questionnaire, the EDQ, which is a 28-item self-report questionnaire that screens for various symptoms of eating disorders. So the core scoring domains here is we'll ask questions about restraint, eating concerns, shape concerns, and weight concerns. And this asks patients to rate these over the past 28 days using a 7-point scale. Some behavioral concerns are included, like binge eating and purging. But to note that there are some behaviors that are not included in the screening, including laxative use, excessive exercise, self-induced vomiting, and objective binge episodes. So just something to keep in mind as well.
Next, we'll move into some of our substance addiction scales. So one of these is going to be the DAS-10 or the drug abuse screening test. So this is a 10-item self-report screener that they rate impact of symptoms over the past 12 months using yes or no responses. So the thing to keep in mind for this one is it does test for cannabis, solvents, tranquilizer, barbiturates, cocaine, stimulants, hallucinogens, and narcotics, but it does not screen for alcohol or tobacco use. So just making sure that you're aligning substances or using other scoring measures for that. The other thing is that with a lot of these measures, they are all based on self-report. So there is a possibility that we could see some underreporting since it is self-report based.
And then the second substance use assessment is the audit, which is specifically to assess for alcohol use disorders, which is again a 10-item self-report questionnaire that asks about questions related to alcohol consumption, symptoms of dependence, and then consequences that someone may have experienced as a result of their alcohol use. And so it asks about these symptoms over the past 12 months using a 5-point scale. And again, some of this they could maybe minimize, right, or underreport symptomology that they might experience. And then scores can also be influenced by limitations such as like different gender, culture, drinking patterns, and underreporting.
Now into some of the trauma scales that we'll use. So the PCL-5 is a PTSD checklist. It's a 20-item self-report scale and uses a 5-point scale. So with this, and this will be one that we bring back up when we get to some of our treatment modalities as well, is that there could be some overlap with symptoms of depression, anxiety, or other trauma-related conditions. And there also can be some fluctuations depending on like recent or trauma stressors that have occurred in the moment. So again, with all of these, we want to make sure these are great indicators, as you can see from a lot of the sensitivity and specificities that we're including on here, is that they have been proven to show that they're great indicators for us. We also want to make sure that we're taking context as to the situation and the way each patient is presenting.
Okay, and then the second trauma-related assessment is the LAC-5 or the Life Events Checklist, which is a 17-item self-report that screens for exposure to potentially traumatic events across the lifespan. And so patients identify the exposure that they've had to potentially traumatic events. For this one, there isn't any established sensitivity or specificity. It is also not used to more like diagnose PTSD, but more just about exposure to different types of events that people may have had. And it doesn't really measure symptom severity. And so response options here also kind of indicate what type of exposure they had to the event, such as directly experiencing it, observing it, hearing about it, or through their job, or not really being sure or not having exposure to the event.
And then we're going to move into our anxiety and, or sorry, we're still in our PTSDs, our ITQ, International Trauma Questionnaire. So this is an 18-item self-report screener. Again, it uses a 5-point scale. The piece to keep in mind with this is that it looks at both PTSD and complex PTSD. So it's able to screen for both. During the first cluster, it looks at PTSD symptoms. And then if it is indicative of PTSD, we can move into the second cluster, which can show screening for complex PTSD. So the scoring can be a little bit complex to make sure that we're indicating all of those markers, but it is pretty self-explanatory as long as the clinician is familiar with the tool.
Okay, and now more anxiety related questionnaires. So first one, the GAD-7, which is again a really commonly used self-report for generalized anxiety symptoms. So patients will rate their symptom impact over the past 2 weeks using a 4-point scale. And again, this is mainly used to look into generalized anxiety, so it may not be as good as detecting other types of anxiety disorders, and also might be a little less effective at detecting subtle clinical improvements as well. But again, the higher the score here, the more severe the anxiety.
And then lastly, we have our STAI, or the State Trait Anxiety Inventory. 20-question self-report, works on a 4-point scale. This one is the specificity and sensitivity are actually based on cases, not diagnostic criteria, but they were able to still grab some of that data based off of cases. The other piece to keep in mind with this is that for scoring, sometimes the items need to be reversed. For example, it may screen, one of these questions is I feel calm instead of I feel anxious. So some of those need to be reversed, which can be to a little bit complex in the scoring again, just to keep in mind for that one.
Okay. So now we are going to shift a little bit into some interventions and integrated treatment and what that could look like for patients and clients. So some of the modalities that we'll be reviewing in a little bit more detail are cognitive processing therapy, or CPT, DBT, dialectical behavior therapy, TF-CBT, trauma-focused cognitive behavioral therapy, psychopharmacology and medication-assisted recovery, and then 12-step. And then towards the end of this too, we will talk a little bit more about what it can look like to integrate a variety of different modalities to kind of, again, serve a patient who might be coming in with more complex needs or a variety of conditions that they might be dealing with at one time. So first one we'll go into is cognitive processing therapy, or CPT. So CPT is a cognitive behavioral therapy, which is treatment that focuses on thoughts and feelings specifically for PTSD, and also has been used for other related conditions like mood disorders as well. So CPT focuses on connecting thoughts, feelings, behavior, bodily sensations, and it is an evidence-based therapy that has been proven to be effective through scientific research. Sorry. Okay, there we go. Okay, so CPT provides a way to understand why recovery from traumatic events is difficult and how symptoms of PTSD would affect daily life. So the focus is on identifying how traumatic experiences change thoughts and beliefs, how thoughts influence current feelings and behaviors. An important part of the treatment is addressing ways of thinking that might keep individuals stuck and get in the way of recovery from symptoms of PTSD and other problems. So pictured here are the 3 developers and founders of CPT, and they started developing it in 1988, and then in 2006, implemented a program to disseminate it throughout the VA systems. It's a very commonly used modality for PTSD. And it's highly structured and manualized. So it's very specific, and you follow a sequence of sessions that are all kind of set up and structured in a specific way. And some of the main things and foundational components of CPT include avoiding avoidance, and this includes avoidance on the part of the patient and also the therapist. So a lot of what CPT conceptualizes maintains PTSD is avoidance behaviors in the patient. And so a lot of CPT is more directive and ensuring that the therapist helps the patient confront their avoidance throughout the treatment in the variety of ways that it might show up, which might include not doing assignments that are part of CPT, missing sessions, trying to kind of like go into a different subject, or all the variety of ways that patients naturally tend to want to avoid. And we know that avoidance is also a way that people cope when things happen to them. Another big part of CPT is helping patients identify what CPT refers to as stuck points, which are similar to core beliefs if you're familiar with more cognitive approaches to therapy. And they separate stuck points into two different types, assimilated and over-accommodated. And so a really large part of the therapy is focusing on addressing assimilated stuck points that the patient has, which are why they believe that their traumatic event happened to them, and then also helping them to address over-accommodated stuck points in the second part of the therapy, which are more beliefs that they've developed about themselves, other people, and the world as a result of experiencing their traumatic event. And then the third foundational part of CPT is the use of Socratic dialogue, which is really important in the role of a CPT therapist, allowing and helping support patients in examining their maladaptive thoughts that are helping maintain their PTSD and helping them, guiding them to a place that they kind of think about things and see things differently. So some of the goals of CPT are to help patients improve their understanding of PTSD and what it is. So many folks will enter treatment with a lot of trauma symptoms or having PTSD and not really knowing that that's what it is or why they're experiencing what's happening to them. Excuse me. So it helps them to be able to understand what recovery from PTSD looks like versus non-recovery, which is really important for the patient to really understand what's going on with them. And then some other goals being to reduce the distress about the memories of the trauma, which will result in improvement of the symptoms. Excuse me. And then to decrease emotional numbing, which again could be part of this like avoidance behavior, right? So there's a big role that avoidance plays in maintaining PTSD. So CPT being a therapy that helps patients reconnect with the feelings that they have about their trauma and help them experience them and feel them. And then some other goals: reduce feelings of being tense or on edge, decreasing symptoms of depression, anxiety, and also guilt or shame, and improve their day-to-day living. It also allows patients to develop really strong thought challenging techniques and other skills that they can take with them after finishing CPT. So it really helps them become highly skilled in identifying thoughts that are rigid and unhelpful to them, and then being able to kind of challenge them in real time, either through like doing a worksheet or just using the skills that they've developed as a result of going through CPT. So CPT typically is 12 sessions, but it can be variable length. Some folks finish it as little as 5 sessions or as a max of about 20. It's usually done twice a week, but can be done once a week if necessary. And patients will get information on their reactions to their trauma, identify and challenge unhelpful thoughts with the structured therapy, and also complete a lot of regular out-of-session homework or assignments to help them kind of practice what they're learning in the sessions, and the worksheets build upon themselves throughout the therapy. So they start with a very basic worksheet, and then throughout they kind of build on each other to become a little bit more complex. Something to note with CPT is really important for patients to buy into it and understand it because it does require a lot of out-of-session work that some patients, if they were unaware of, they might be surprised by. And so some topics that are covered is the meaning of the traumatic event. So usually folks with PTSD will come in with a story about the meaning of the trauma and why it happened. And it's based usually on what they've told themselves about why the event happened. It's usually not based about the actual facts of the event. And so something that we help folks do in CPT is kind of get back to the context of what was actually happening at the time of the trauma to be able to kind of like bring back some of those facts that might have been kind of like pushed to the side because of what they told themselves about why it happened. And then also identifying thoughts and feelings. So we really teach patients the skill of what is a thought and what is a feeling. So many folks sometimes will say like, I feel that, and then they'll say a thought, which is not necessarily an emotion or a feeling. So we really reinforce and teach what is a thought versus what is a feeling. And then we also address multiple identity modules here, which are trust, safety, power and control, esteem, and intimacy, which are all areas of identity that are usually highly impacted by experiencing trauma. And so we help patients explore their beliefs and their thoughts, or their stuck points, as CPT would call them, to help them kind of challenge those thoughts and get to a more balanced way of thinking. And then some things to note here with CPT and comorbid symptoms is that 49% of a sample from a study reported a current or past diagnosis of alcohol use disorder, and veterans who had an average of 9 sessions of CPT. There were no differences in the treatment results amongst those who didn't have an alcohol use disorder history, those with a history of alcohol use disorder, and those with current alcohol use disorder, meaning that it was effective regardless of whether or not patients were experiencing symptoms of alcohol use disorder. CPT has also been found in studies to reduce hazardous drinking, meaning that folks who were currently drinking in a problematic way as a result of going through CPT were able to reduce hazardous drinking. And integrated CPT and eating disorder treatment resulted in significantly greater improvements in PTSD symptoms than eating disorder treatment alone. And also, patients had a higher preference over the integrated treatment over just the standard eating disorder treatment. And last thing I will note with CPT that the founders talk a lot about is fragilization of patients. And so I'm sure many of us have kind of like heard, and I myself have historically said, like, they're not ready to do trauma work, right? Because they're experiencing symptoms of addiction, or they're experiencing other things that they're kind of coming into treatment working on. And they actually find that waiting to do trauma work because patients, quote unquote, aren't ready, is oftentimes more harmful than helpful. And there are very few instances in which like waiting is actually clinically indicated based on research. And it also can indirectly send the message to a patient that they can't tolerate their trauma, which is in fact part of the avoidance that is maintaining their PTSD. So I really like to emphasize and enjoy kind of the term fragilization as something to remember, that that's something that we may unintentionally do as a part of treatment that could actually impact the patient in a negative way.
Thanks, Michelle. The next focus that we're going to look at is trauma-focused cognitive behavioral therapy, or TF-CBT. So this again focuses on trauma. The difference between CPT and TF-CBT, besides the modality, obviously, is that this focuses primarily on children and adolescents, versus CPT is approved for adolescents and adults. So TF-CBT is an evidence-based treatment for children and adolescents that are impacted by trauma, as well as their parents and caregivers. Research shows that TF-CBT successfully resolves a broad array of emotional and behavioral difficulties associated with both a single as well as multiple and complex trauma experiences. So it can be utilized in a variety of ways for our adolescents and children. TF-CBT was developed by Drs. Anthony, and excuse my pronunciation, Marinano, Judith Cohen, and Esther Diblinger. TF-CBT is evidence-based treatment. It's been evaluated and refined by the past 30 years or so to help children and adolescents. So what this looks like is it is a short-term treatment model that looks at between like 8 and 25 sessions for both the child adolescent as well as the caregiver. They're an active participant in this treatment as well. Although TF-CBT is effective and proven to work on improving PTSD symptoms, a PTSD diagnosis is not required in order to go through TF-CBT treatment. So it works on addressing other trauma impacts like effectiveness, like affect, cognitive behavioral problems, as well as the connection and relationship between parent as or caregiver as well as the child or adolescent, effective parenting skills, and supportive interaction with their child. The basis of CBT focuses on this practice area, which goes through three phases of what the trauma work looks like. So phase one focuses a lot on the stabilization and skills. So I'll break down these a little bit further in the next couple of slides here as well. So for the first letter, P in our practice works on psychoeducation and parenting skills. So the goal of this is to learn about trauma, learn about common reactions. We want to talk a little bit both with the individual or the adolescent or child that's going through this, as well as the parent, and this looks different for each individual. The goal is to both normalize the trauma response, foster hope for both parties, as well as to provide education for the parent and education on how to navigate these symptoms. The adolescent or the child is going to be going through these trauma responses, and the parents need help in supporting the child and what that looks like. We also want to teach the child and adolescent what is happening to them, because although they may or may not understand fully what's going on, so teaching the brain and body connection is going to be really important for them to fully understand the symptoms they're experiencing. We want to work on reducing shame and self-blame for both as well, because a lot of times, not only is the child or adolescent experiencing these pieces based off of the trauma response, but so is the parent holding some of that guilt and shame as well. The next phase is looking at relaxation. So we are going to be working on diving into this and kind of breaking down these pieces, but we want to make sure that both the parent as well as a child or adolescent have the ability to regulate themselves through this process. If we just work on all these activating features and not bringing them back down, it's going to worsen that relationship and just ultimately impact the trauma symptoms even more. So we want to make sure that we're working on psychological arousal as well. So we're going to do some deep breathing exercises. We're going to work on progressive muscle relaxation. We're going to bring in guided imagery, mindfulness, and grounding. The important piece as well is that this really needs to be a well-rounded approach for everybody involved. So if the caregivers or the adolescent or child is not open to experiencing this, it's going to be really difficult because it needs to be something that the adolescent and child needs support from the caregivers to engage in these coping skills as they're going through these really intense sessions. The next step is going to be effective expression and regulation. So we're going to teach about identifying emotions, what emotions are actually coming up for them. We're going to bring out a feelings wheel. We're going to talk about what this looks like for you more so than I'm mad or I'm sad, because we want to understand what actually is coming up for the adolescent. We're going to work on how to express these appropriately, right? So instead of engaging in some of these maladaptive behaviors, how do we communicate what's going on? We're going to work on regulating the intense emotional responses and increasing our emotional awareness for our adolescents and children, as well as the caregivers that are supporting throughout this process. The next step is going to be cognitive coping. So this is where we really dive into that thought, feeling, behavior connection. So all of these pieces are going to be coming up, and we're going to teach the adolescent how to identify these and challenge the unhelpful thinking patterns. These distorted beliefs that are kind of intertwined with this trauma or with this experience are going to really be examined and replaced with more adaptive thoughts. Again, with the support of the caregivers. Now, the caregiver is not going to be in every session, knowing every detail of this, but they are going to be supporting in the way of making sure that the child and adolescent is feeling safe, secure, and supported throughout the process. And we'll see as we reintegrate them back in towards the end as well. The next piece is going into our trauma narrative and processing. So this is going to be gradual exposure to the trauma memory. This can look very different based on the participant and what feels like the best way for them. They might be doing more of a drawing project. It might be more of a journaling experience. They're going to work on either written, verbal, or creative narratives to really explain what's happening to them, which is ultimately the goal to process that shame, blame, and again, those similar stuck points that we're talking about in CPT are again being addressed in the TF-CBT here. So we're helping to reduce avoidance. We really want to face what's going on in our lives, and we want to modify those unhelpful beliefs associated with the trauma. We're going to reform them into more adaptive coping mechanisms and more adaptive thought processes. As we move into I is going to be in vivo mastery of trauma reminders. So this is going to, again, look very different based off of the patient. It's a little bit less of manualized than the CPT that we were just talking about, because this is going to look different based off of the trauma response, based on the child, based off of the situation. So gradual exposure to trauma reminders. This is going to be really worked out with the adolescent, as well as caregivers can be involved in this as well to make sure that it's something that is feasible to do. The goal of this is to reduce avoidance in real life and build confidence and mastery. So we're kind of navigating some of those hypervigilant symptoms, some of those isolative symptoms, to make sure that the child is able to really go back into the world and feeling like they are able to do that confidently. Next is the conjoint child and caregiver sessions. So we really want to do this to share the process. We want to improve communication. If the child is feeling up for it, then they can process some of those aspects of the trauma together. That always is going to be based off of the judgment of the clinician as well, whether or not this is appropriate, whether or not the child is on board, and what this looks like. The ultimate goal of this is to strengthen the caregiver support, to understand how they can help support the child and adolescent through the continued process, as it will be more of a lifelong adventure, even though they're still facing this in the moment. And then the last step is to enhance safety and future development. So we're really going to work on personal safety skills, healthy boundaries, relapse prevention, future coping strategies, building resilience, and empowerment. So this is, once we have fully processed the trauma, we really want to work on how do we make sure that this is not having lifelong impacts on our adolescents. If there was concerns with safeties and boundaries, how do we work on navigating those and understanding that moving forward? So this can look like psychoeducation. This can look like safety planning. This can work on a coping skill toolbox. This can work on support systems. Again, really the dynamic that's at play for the adolescent.
All right, so now moving into everyone's favorite, DBT, dialectical behavior therapy. So just kind of conceptualizing DBT in treating, if we were to think about kind of like treating someone with a more complex presentation like PTSD, eating disorder, substance use disorder, and even kind of combining this a little bit with, some of the modalities we just talked about, like CPT or TF-CBT, is DBT can just be a really good like adjunct approach to help mostly with skill building. So I think it's just like easy to integrate DBT with a lot of other modalities. And so when we think about kind of like integrated treatment, someone could be learning DBT maybe in a group format, right? And also simultaneously be doing a more trauma specific program individually, right? Whether that be CPT or TF-CBT or something else like that. So with DBT, Marsha Linehan developed this back in the 1980s, and again was more like formal manualized treatment that had been developed to help chronically suicidal patients that had also been diagnosed with borderline personality disorder. But we know today that it's really a gold standard and helpful for everyone, to be honest. People with a lot of different conditions like substance use, depression, or mood disorder, PTSD, eating disorder. And really is just, I think, helpful for everyone to have skills that they can use to help them cope with their emotions in different parts of their life. So getting kind of into a little bit more about the foundations of DBT. So it's focused on the concept of dialectics, meaning like two things that feel like opposing can be true at the same time. And the biggest dialectic in DBT being acceptance and change. So when you think about the skills for DBT and the four pillars, the acceptance skills being mindfulness and distress tolerance, and the change skills being emotion regulation and interpersonal effectiveness. So the components of a more full fidelity DBT program would include individual therapy, being part of a skills training group that teaches all the different skills of mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. Would include phone coaching as like an option with a therapist or clinician to help them with real life situations that might be coming up outside of treatment. And then also includes like a consult team for the therapist to maintain fidelity to the treatment and reduce burnout. Not every program needs to or does offer full fidelity DBT, but many and most programs combine, different DBT skills as a part of like other modalities that they offer and teach to patients. So a little bit more about the different parts of DBT. So mindfulness teaches individuals to focus on the present moment with openness and without judgment. And some of the skills that are a part of this part of DBT include the what skills, which would be observe, describe, participate. The how skills, meaning non-judgmentally, one mindfully and effectively. And then we also discussed the states of mind being emotion mind, reasonable or rational mind, and wise mind to help folks kind of become more aware and attuned to how they might present and how to access wise mind or the middle path when they want to or need to. And so the goal with mindfulness is to increase our awareness of ourselves and to reduce impulsive reactions to different situations that we might experience. And then distress tolerance is more for an emotional crisis. So when your, distress subjective units of distress are very high, like an 8 to a 10, you're experiencing kind of an emotional crisis and you can't access some more of those like logical skills. These would be great skills to use. And so focusing on coping with a crisis or a painful situation without making it worse. So some of these skills include tip, stop, accepts, and radical acceptance. And so the goal with distress tolerance skills is to use them in the short term to kind of reduce our level of distress so that then we're then able to access other skills as well. So self-soothing, distraction, improving the moment, things that allow us to tolerate the emotional pain, again, until it becomes to a more manageable level that we can, implement other skills as well. Interpersonal effectiveness is more related to our relationships with others and teaching healthy communication and relationship skills. So the main skills here being dear man, give, and fast. And they help us to be able to ask for our needs effectively in a relationship, how to say no or set a boundary, how to manage conflict, and also how to maintain our self-respect and also be able to maintain our relationships. And the goal with interpersonal effectiveness is to help us build healthy, more balanced relationships while also maintaining our own personal values. So these skills, again, you wouldn't be able to necessarily access an emotional crisis, but they're useful and helpful in engaging with other people and to kind of like help us address conflict and different challenges that come up in our relationships with folks. And then emotion regulation skills help us to understand and manage our intense emotions. Skills here, some of them being like check the facts, opposite action, please skill. And a lot of this is teaching and helping people to be able to identify their emotions and what they're feeling and experiencing, reducing our vulnerability to emotional distress, having access to increase our positive experiences, and being able to problem solve. And this is helping teach, and the goal here being to experience our emotions without becoming overwhelmed by them or feeling like we need to get rid of them or change them. But really allowing us to connect with those emotions and be able to cope with them.
Next, we're going to move into medicated assistant recovery, or MAR, as well as psychopharmacology. Now, we could do a whole presentation on this itself, but we are going to condense it down just for the sake of this purpose and really just do kind of a small overview of what this can look like. So the use of medications in combination with counseling and behavioral therapies provides that whole patient approach that we've been talking about when we're looking at treatment of substance use disorders, eating disorders, PTSD, that individualized care. PTSD medications mainly include SSRIs and SNRIs. Sometimes these can include prazosin and some antipsychotics. Medications used to treat eating disorders are mainly adjunct to the psychotherapy and nutritional rehabilitation, as the evidence is much stronger for bulimia nervosa as well as binge eating disorder than anorexia. So right now there's two medications that are consistently identified as FDA approved across literature. So it's fluoxetine for bulimia as well as lisdexamfetamine for binge eating disorder. These are also used a lot for substance use disorders, which I think sometimes can be what we think of when we think of medicated assisted recovery. So some of these in particular for alcohol use disorder include disulfiram and naltrexone. Those are some of the most common used to treat alcohol use disorder. Although they don't provide a cure for the disorder, they are effective for people who participate in treatment programs as an added piece to that well-rounded treatment. Similarly, when we look at medications for opioid use disorder, we look at methadone, naltrexone as some of the common medications approved that are FDA approved to treat opioid use disorder. The medications help normalize brain chemistry by blocking the effects of alcohol and opioids. They relieve some of the psychological cravings as well as restoring normal body functions. The medications are effective in treating opioid use disorder related to the short-acting opioids such as heroin, morphine, and codeine, as well as the semi-synthetic opioids like oxycodone and hydrocodone. They are safe for long-term use, ranging from like months to lifetimes. Again, this is a really short overview of what some of this can look like. There's a lot more into it, but for the sake of this presentation, this is kind of the main pieces that we wanted to focus on.
Okay, and then the last more like specific modality before we talk a little bit more about integrated treatment is a brief overview of 12-step and 12-step recovery. So the history here is that AA began in 1935 of a meeting between Bill W. and Dr. Bob S. in Ohio. And 12-step is a structured, peer-supported approach to recovery, and it's now used across many different substance use, other addiction, and also kind of has spread into like different support groups as well, for really anyone in recovery, even if not from addiction. So some of the key principles of 12-step include a more abstinence-based approach to recovery. It's highly rooted in peer support. So it's not run by a trained professional necessarily. It's peers that are part of the community that are facilitating the meetings, involves sponsorship, shared lived experience. There is the concept of having a higher power, which again can be spiritual, religious, doesn't necessarily need to be religious, and is defined individually by each person and is a lifelong process. So they really view it as something that recovery is not time limited. You don't really just achieve it and then it's done, that it's really an ongoing process, and being a member of this group kind of helps you to be able to maintain what you've accomplished in your recovery. So some common 12-step and other similar groups that many folks may have heard of are AA, NA or Al-Anon, which is more for like family members of people with addiction, Gamblers Anonymous or GA, Overeaters Anonymous, OA. We have some similar meetings that are not necessarily found in the 12-step principles, but are still peer support recovery, such as Smart Recovery, Recovery Dharma. And then a couple other 12-step, Codependence Anonymous, Eating Disorder Anonymous. And there's also a lot of different support groups that folks can attend to be a part of a community. So really the thought behind this is that community helps to facilitate connection, right? And positive connection that helps people to achieve and maintain their recovery, because we know that no one can really do this work alone. And the more people that we have to support us in our journey of recovery, the more successful we will be. And it's usually helpful to have more peer support as well, in addition to the professional support we may be receiving from a treatment program. And then a little bit about the 12 steps here. And again, the 12 steps, of course, they're like founded in AA, but they really are a way to think about living a life worth living that is aligned with your values. So I personally don't think that these inherently need to be a part of like 12-step, but that they really could apply to anyone. So I won't read all of these necessarily, but just wanted to include them here for our review. Okay. And now moving into more integrated treatment. So I got this graphic from an article from Dr. Brewerton, who has a lot of good information about what integrated treatment can look like. And I thought it was just a helpful visual to kind of establish and facilitate some discussion about what this can possibly look like. It's a little complicated. I know there's a lot of words here, but we'll kind of like break this down a little bit. But basically, kind of like looking at the top of this graph here, kind of like models what integrated treatment could look like. So the first part being in assessment. So doing a comprehensive assessment at the time that obviously we start working with someone, we hope to gather a lot of good information about what they're currently experiencing and going through. That will help us then kind of like look at what their treatment could look like. We also know that there's some limitations, right? That folks don't always feel very comfortable sharing certain things with us the first time that they meet us. So assessment being an ongoing process that doesn't just happen once at the beginning of treatment, but that we continue to kind of learn and gather information as we go. And after that assessment, obviously, it will help us conceptualize diagnoses that will then help us kind of look into like what treatment can look like for this person and what might be most helpful. Um, and then we'll also be like looking at responses, to the treatment that we implement. Some other things to know with like assessment is a lot of those assessment tools that we previously discussed would be helpful things to kind of get from folks at the beginning of a treatment episode, just in case, again, we missed something, or we didn't ask them certain questions, or just to kind of get a good well-rounded clinical picture. We know that patients frequently experience being misdiagnosed or incorrectly diagnosed when they enter a treatment setting. And so the more information we have about what's going on with them, the better. And then kind of looking at the left side of the screen here, we'll kind of like break down what these different components look like. But part of after kind of like the assessment and treatment planning process, providing psychoeducation, making sure that we establish safety. So any safety related concerns that a person may have. And yeah, we'll kind of like get more into this, but then it kind of flows into what are some of the components of integrated treatment. So here we mentioned a lot of these different modalities today, being like CPT, TF-CBT, could also involve some other things like EMDR. It mentions DBT skills, ACT, interpersonal psychotherapy, 12-step yoga, and then psychopharmacology treatment as well. And looking at an abstinence versus harm reduction approach and what might be most applicable and helpful to a person. And then moving them towards a place of maintenance and remission. And then also kind of like what happens in the case of a relapse. So I just like this visual aid as.
All right, so next I think we're having some connection issues here. So next we're gonna go into this a little bit further in regards to what the treatment model looks like. I know Michelle touched on this, but we wanna dive in a little bit further. So what this is gonna look like is first off looking at the assessment. So we've talked a lot about these assessments overall. We've gone through some examples. By no means is this an all-inclusive list. These are some assessments that we utilize in our own practice right now that we have found to be really effective in navigating. We find a lot of times that, we might have an understanding based off an assessment of what a client comes in with as they're presenting problems or diagnoses. And through making sure that we complete a wide array of assessments, we actually find maybe there's a trauma diagnosis that has been missed over time for this. So we want to make sure that we're really conducting an all-inclusive assessment piece to make sure that we're picking up on substance, even if that wasn't something that initially they identified as a problem area. The psychoeducation piece is really important as well because we want to make sure that the patient knows what we're treating them for. So let's say they came in and didn't know that they had a trauma diagnosis. We want to provide some education on that. We don't want them to see a treatment plan and see a trauma diagnosis and not understand what that looks like for them. So we want to make sure that we are providing psychoeducation on what is this diagnosis and how are we going to support you in this. We want the client to also feel like they are in charge of their treatment because ultimately it is their treatment, right? So we want to make sure that we're including them to make sure that they are in charge of what this looks like for them. Somebody might be open to engaging in CPT. Somebody might be really upfront and honest and say, do you know what? I'm not ready to do that intensive trauma work at this time. So we want to make sure that we are navigating their treatment based off of what they're willing to do, as well as the clinical recommendations of the treatment team. Safety and stability are going to be really important because we cannot treat somebody if they are not in a safe spot. So that's going to be something that we initially assess upon the beginning of their treatment episode, and that's something that we are going to regularly assess. Depending on the level of care, this may be daily to make sure that the work that we're doing is keeping them in a safe place where they can continue to do the work. Safety and stability looks different for every patient. So we also want to look back as to what is the patient struggling with? Is this somebody that has safety concerns in regards to the harm to themselves or others? Is this somebody that we want to look out for substance use or eating disorder concerns? And making sure that the whole treatment team is, including the patient and the support people, are involved in that to see what that looks like. We also want to make sure that we're identifying the readiness for change. So we want to see where they're at because that is again going to impact where they're at. Maybe their readiness for change is still in that pre-contemplative stage, so we're not ready to dive into some of these more intensive treatment modalities, and maybe we want to work on some motivational interviewing to get them to that point. It's going to be really interwoven into all of this now. So the next kind of steps for this is going to be looking at nutritional rehabilitation. So that we want to make sure that we are assessing early on and that the patient is going to be adherent to this plan. So again, we want to make sure that we're incorporating the patient in this because if we prescribe a nutrition plan that the patient is not on board with, they're not going to follow through with it. And that's going to lead to both a lack in follow through with that plan, as well as a lack in ability to navigate that treatment episode. So we want to make sure that it is in congruence with what the patient is looking for and their support. The next thing we want to do is look at behavioral monitoring and response prevention. So we're going to monitor those symptoms and we're going to make sure that we're framing the various degrees of symptom improvement and evidence and success. A lot of times we may see a patient who is really, having several depressive episodes. This is not their first treatment modality, this treatment episode, and they're coming in and as clinicians, we're seeing these great improvements that this patient is making, but maybe they are not able to see those. So the assessment tools are another way to recognize that and to show, hey, when you came in, your PHQ-9, was a 21 and you're sitting at a 15 today. Let's see what this looks like for you. So sometimes looping in those assessment tools, as Michelle had mentioned, throughout all of the treatment is going to be really effective for both the clinician and the patient to see progress and to see what that looks like. We also want to make sure that we're looking at adaptive function. So collaboratively identifying the relationship between life events, symptoms of PTSD, eating disorders, and how they may serve. So we want to make sure that we're validating that avoidance, the numbing, the decrease in hyperarousal, regulating trauma-related stress, and making sure that we're really working together with the patient. And that's where we talked a little bit too, is that we want to make sure that we're identifying stressors and indicators that may also skew our results from our assessments and how we work to bring that back in to the clinical work we're doing with our clients and our patients. All right, a couple more steps here to make sure that we're really integrating our care is working at components of the integrated treatment or the psychotherapy. So that's where we're going to look at CPT, the prolonged exposure, the EMDR. We're looking at TF-CBT, CPT, all these different modalities that we're utilizing. And this, again, by no means is an all-inclusive list, but we want to make sure that we're implementing the best modalities that we can based off of the presenting issues and symptoms of that patient. So it could look different. It also may look different based off of what the client or patient is open to utilizing themselves. 12-step is a great way to build community and camaraderie within the recovery process, but not every person is willing to do that. So we want to make sure, again, that we're matching and evaluating it individually based off of the patient. We're also going to look at the components of the integrated treatment, like the psychopharmacology and neuromodulation that we were talking about. So we can look at antidepressants, antipsychotics, naltrexone, all of these different pieces as well by a medical provider. The last couple of phases to make sure that we're looking at this is going to be resolution, abstinence, or harm reduction. There are a lot of different ways that we can go about in treatment for these, and we need to make sure that we, again, are matching this based off of what is best for the patient and the client and what is best for what they're willing to do as well as what they're going into treatment for. So we know that improvement in one set of symptoms often results in a resolution or improvement in related symptoms. which exists within a network of each other. Maintenance, remission, and relapse prevention is going to be an important space for anybody with any sort of mental health struggles, whether that be trauma, eating disorder, substance, or any combination of these pieces, because we know that these are lifelong areas of focus. They're not something that can be completely vanished in one treatment setting. So we want to make sure that as we're working on improvements, we're looking at different phases, how we're going to work on maintenance, relapse prevention plans, safety plans, and things like that. And the refractoriness and relapse. In the face of refractoriness of treatment, inadequate response, and a relapse, which is common, it's helpful for the patient and the therapist to reevaluate the treatment plan, identify triggers, stuck points, and revisit the therapeutic options, because this is going to be ups and downs. It's not a singular line of recovery, and making sure that we are adapting based off of any struggles that come in the door are going to be really helpful for the long-term success of the patient. Anything to add, Michelle?
No, I'm so sorry about me losing my internet, everyone. Hopefully it will work now. Um, okay, so I think that brings us to our conclusion, and we are free to answer questions that folks may have.
So Michelle, one of the questions that are coming through is how would you navigate vaping or other more socially popular or acceptable substances as a form of substance abuse? And how can you know if these are tipping into substance abuse rather than just substance use?
Yeah, that's a great question. I think one that and we at SunCloud come across and struggle with as well. Um, One thing I think about is person, and that being something that might influence how I might respond to that. But also if in terms of like knowing whether it's tipping into abuse, I would say just like looking at the impacts of the behavior, and using that as a way to kind of like guide if it's something that's harmful to a person. And helping them maybe increase their motivation to be a little bit more like interested or motivated to work on the behavior. But I will say that that is one that is particularly challenging to address. Yeah. Am I breaking up?
You were a little bit at the beginning, but it seems a little bit better now. Oh, Kelsey, we have another question in here. We actually have two questions in here about harm reduction. So in what scenarios would that work within the model as opposed to abstinence? And what does that look like? And when do you recommend it?
Yeah, that's a great question. And it really is case dependent. So, some of the things that you want to consider when you're thinking about what type of model you want to utilize is what are we working with, right? Can we use abstinence-based and eating disorder? Probably not. We're going to look at more of a harm reduction model for that. We want to see as well the age of the person. So if it's somebody that is under legal age, we might work at more of an abstinence-based versus a harm reduction model. We want to look at the impact on daily functioning. So are we able to navigate going to school, going to work? What is the substance or what is the thing that we are looking to be abstinent or decrease use in? So there's a lot of different factors that we want to keep in play to make sure that we're treating the patient the best. Is a lot of it too comes down to what the patient is willing to do. If we're only willing to work at a harm reduction model, that's okay. We want to make sure that we're meeting them where they're at in goal of long-term safety.
We are getting a couple questions about marijuana. So how do we handle marijuana or other recreational drugs? Is there any medications that can assist with marijuana, etc.?
Yeah, so we always want to make sure that we're consulting with medical providers in regards to medications or things like that. There have been some studies, I believe, that look at buspirone with cannabis use disorder. The other piece too that you can really consider is that, like we've talked about this whole presentation, is very minimally are these a single diagnosis. So I can't tell you how many times, I don't think I've ever seen a singular cannabis use disorder diagnosis with no other diagnoses involved. So we want to make sure that we're looking at the whole picture. So maybe there isn't something pharmacologically that we can do for the cannabis use, but maybe we can treat the underlying depression that's actually stemming the cannabis use. So making sure that we're looking at the whole person is really going to be effective for navigating that.
This one's an interesting question about Ozempic type treatments for people who don't seem overweight. Are you concerned with Ozempic leading to unrecognized eating disorder behaviors?
Yeah, that can um yeah, that we've definitely seen that. And I think that's a very common thing that's happening in, in our society today. But again, I think that's like part of assessment and information gathering and getting to know a patient and treating them is, again, looking at like why they're prescribed, Ozempic or any GLP-1 and assessing them in the context of like other behaviors and things that might be going on with them. Yeah.
We also have questions on treatment resistance and chronic relapse. What are your thoughts on that?
Yeah, I think there's definitely a higher prevalence, especially with people with having multiple diagnoses as well. So I think treatment resistance is really helpful to understand where that resistance is coming from. Is it because they've been in treatment so many times that they're really feeling hopeless and helpless? Is that something that we can work on in treatment? And making sure that we're addressing the underlying root cause is going to be really effective for that. Are they feeling unheard by their clinicians? Is their treatment plan something that they don't want to work on when they're in treatment? So making sure that we understand that can be really helpful. Chronic relapse is a part of recovery as well. Making sure that we're not focusing on guilt and shame and we're focusing on what do we want our life to look like can be helpful. Coming up with relapse prevention plans and safety plans when we're looking at transitioning out of levels of care to make sure that we do our best to prevent it is also going to be really effective.
hmm I think another thing with resistance or chronic relapse too, and we think about kind of some of the things we've talked about today is that treatment centers might be not adequately addressing what's going on with a person. So if they're going into treatment with a variety of, things that they might be experiencing, but the treatment center that they're at is only talking about one, it could be like something that's going on with the treatment that's not really working for the patient. Yeah.
We also are getting a question about microdosing ketamine. They would like to know what your thoughts are on that.
Yeah,
Um, oh, go ahead.
go ahead, Michelle.
Um, well, obviously, like, ketamine being, Spravato and ketamine being used to treat treatment-resistant depression, obviously under, a medical provider, um, and that is found to be effective for treatment-resistant depression. I'm not sure if you're meaning like recreational substance use, which obviously I would not recommend, but I think, ketamine is proven to treat treatment-resistant depression. Yeah.
We had a question about harm reduction in our IOP setting. So can you talk a little bit about how in our outpatient programs we handle the harm reduction plans or strategies?
Yeah, so that's going to be really individualized, which I know is probably not the answer that you are looking for this one, but that's really the kind of what SunCloud is we individualize treatment for everybody. So in our day program, in our in-person program versus our virtual program for IOP, it looks a little bit different as to like what kind of we can accommodate, what we can help support. But again, it's really going to be based off of what that client is presenting with and how we can help support them.
We have another one coming in about how do you work with reluctant teens and get them to open up and get motivated, stay motivated, particularly in teenage males.
This is my favorite. I think it comes down to understanding where they're at. A lot of times, especially with some of our teen males, particularly with their substance use diagnosis, we see a lot of just like not wanting to be in treatment because they don't see anything wrong with what they're doing. It's effective for them, right? They're having maybe symptoms of depression or anxiety, and the substance use is effectively masking that. So it comes down to really kind of working with them to see, is this something that they want for their life? It might be. And is there some ways, do we have goals and aspirations that maybe using substances or kind of having this outlook might not be helpful for? So it comes down to a lot of meeting them where they're at, understanding what their goals are and helping them reach their goals, which may look different for everybody, but understanding how do we get there as a team rather than me coming in as an authoritarian figure to like tell you what to do with your life.
We have another one that says, when a client presents with a complex presentation, other than safety, how do you decide on the prioritization of symptom focus? Prioritizing which mood issues, eating disorder, any specific way that you integrate your interventions?
So I think that's
Um,
part of, go ahead,
I'm
Michelle.
sorry. I think my internet is cutting out a little bit. In terms of prioritization of symptom focus, I would say, obviously knowing what all of them are, but I would say what feels like to the patient is impacting them in their daily life the most is where I would usually kind of focus. Like, I would let the patient guide where we start and let them tell me what they feel is like the most impactful thing for them, while also acknowledging and knowing that like there might be some things also that we work on simultaneously or work on later on in the course of a treatment episode. But I usually let the client tell me where they would like to start. Yeah.
Yeah. I think the other thing to really consider too is not feeling like you have to fully treat one before going to the other and making sure, like, yeah, we can start with maybe suicidality and we can also loop in eating disorders and substance use at the same time and making sure that we're not feeling siloed in that.
hmm And then in terms of the second part of integrating interventions, I think it depends on the setting, like in a setting like ours where it's a higher level of care, they would be attending some groups to get some of the skill education like DBT and things like that, where then like individually we might do a more like trauma specific intervention like CPT or TF-CBT. Um, but in terms of like integration, I think that varies a little bit depending on like the setting that you're working into.
We are getting some questions about the synthetic opioid kratom usage, just being a large increase, being more popular at the treatment center that they work at, also not really being covered or taken seriously under insurance for residential stays. So, do you have any information or resources or suggestions on how to best handle that?
I think it's something that we're definitely seeing on the rise. I wish,
We have not seen a
go for it, Michelle.
No, it's okay. Go ahead. Go ahead.
So I think we've definitely seen it on the rise. I don't think we've had a ton of it with our population as of yet, but I know it's coming up there. We've started seeing a little bit more. I wish I had a good answer for you as to how to handle this, but I think it's something that we're going to have to continue to work on, and kind of get creative with for treatment and coverage and all of that. I think it's similar to when we were talking about Delta 8 and these different pieces that we will, I think, always have new things coming up, and trying to navigate how they come up with is going to be complicated.
Well, thank you everybody so much for attending and turning in your questions. This was such a great presentation. Thank you, Michelle and Kelsey. Just as a wrap up, with SunCloud Health for adults and adolescents, we offer residential PHP and IOP. We do have some immediate openings in our adolescent Chicago program. If we can be of any help or assistance to you, you can reach out to Diane or myself. Or if you'd like to get more connected with Michelle or Kelsey, also feel free to reach out to Diane and myself, and we can get you guys connected there. If you had a great experience with us, we encourage you to leave a review. There's a QR code up. If you're willing to scan it and leave us a review, we'd appreciate it. Thank you guys so much, and have a great rest of your week.